Good evening, everyone, and welcome. Thank you for making the time today to join us for what I know is going to be just a really terrific webinar. My name is Janet Heischetter, and it's my honor to serve as the Executive Director for the Dystonia Medical Research Foundation. Before we get started, just allow me to make a few announcements about the webinar. The audio for today's webinar is available via telephone or through your computer speakers. Due to the large number of participants we have this evening, everyone except for our speaker will be muted automatically in order to keep the background noise to a minimum. If you're using your telephone, please make sure that the phone call button in the audio pane of your attendee control panel is selected. You will also need to enter the audio pin that is shown in your audio pane and turn your computer volume off. If you're listening via your computer's speakers, please be sure to select the computer audio button in the audio pane of the attendee control panel. Your questions are an important part of this program always, and we encourage you to write them in the question pane on your screen as you think of them, and we'll do our best tonight to get to as many as we can. If you have any technical difficulties during the webinar, please email Jody Roosevelt. Her email address is here listed on the screen, and she will do her best to assist you. So now we'll get on to our program. Tonight's webinar is entitled Untangling the Complexities of Dystonia, 40 plus years of DMRF research and achievements. Our founders, Fran and Sam Belsberg, from the very beginning were dedicated to building a significant, robust, collaborative, and really global research program. The DMRF board has continued this commitment to this approach, and the foundation has always funded the best science and worked to engage young investigators regardless of borders. Nearly 15 years ago, the DMRF brought on our own full-time scientist, Dr. Jan Teller, as our chief scientific officer and advisor to push the dystonia research every day. As a small organization, this was a really big deal for us. But again, I think it reflects the foundation's commitment to finding answers for you, members of the dystonia community. The DMRF has been fortunate to work with the world's best medical and scientific advisors who are incredibly generous in providing their time, their expertise, and guidance on the direction of our research programs so that we can get the most for our money and expedite discovery. At the top of the list of those advisors, the DMRF is lucky enough to work with Dr. Joel Perlmutter. Dr. Perlmutter is the Elliot Stein Family Professor of Neurology at Washington University in St. Louis, Missouri. Dr. Perlmutter received his BA from Princeton University and his medical degree from the University of Missouri. He did his residency and a neurology fellowship at Washington University. He's a world-renowned movement disorder neurologist and investigator. In addition to treating patients, Dr. Perlmutter is widely published, has expertise in many areas, including imaging, and his research is supported by the National Institutes of Health. He's a champion in supporting young investigators entering the dystonia research community. Dr. Perlmutter is the co-PI for the Dystonia Coalition, an NIH-supported research collaborative effort, and has been a longtime member of the DMRF Medical and Scientific Advisory Council and frequent speaker at patient education programs and community events. I'm proud to say that Dr. Perlmutter serves as a DMRF scientific director and is an ex officio member of the board of directors. I want to thank him for joining us tonight, for his efforts in developing this presentation and helping us understand the developments in research, and also for everything that Dr. Perlmutter does for the DMRF and for dystonia. It's now my pleasure to turn the program over to Dr. Perlmutter.
Thank you very much. Let me get started here. Okay. Thank you very much, Janet. And I also want to thank for that very generous introduction, and also thank Jody Roosevelt for making all of this happen. She's just incredible in her skill set and her kindness and generosity. What I'd like to talk about today really is about research in dystonia. And I want to talk to you about what's gone on for the last 40 years, almost exclusively because of what the Dystonia Medical Research Foundation started and continues to support. And it really began with Sam and Fran Belsberg searching out for their child, what to do about this child that had this condition. And when they went to the doctor to find out what it was, and they went to many different doctors, and they finally came down to Southern California, and the doctor said to, and they asked the doctor, so what is it? And they told him that the doctor told them it was dystonia, and so they said, now what do we do? He said, well, we don't know. And so the Belsberg said, well, what can we do to make that better? And then they started the Dystonia Medical Research Foundation. And that has been just an incredible influence. And I want to give you a sense of how that has affected research over the years. And let's see if I can go to the next slide. Okay. And so the Dystonia Medical Research Foundation supports research, training new investigators, educating clinicians, as well as families and people that have dystonia, helping to improve care and support, and ultimately to help develop new treatments. These different areas are not really different. They're all intertwined. My topic today is really research, but as I go through this, you'll see how each of these parts interact and are important with each other. And to give you a sense of how the DMRF has been such a major game changer, the DMRF, which started in 1976, prior to that, in the world scientific literature, there was about 6 papers a year published about dystonia. Once the DMRF was established in 76, in the next 4 years, there were now 29 papers a year. And then more recently, over 300 papers per year. And I think this directly reflects the support of the DMRF for young investigators and to start new research programs. The National Institutes of Health, in fact, supports much of the big research that's done on dystonia. But in 1985, there were only 6 grants from the NIH that were involving dystonia. And by 1990, really only 3 that year. And in fact, in one of the grants submitted to NIH for a proposal on dystonia, it was reviewed by the members of the review committee and thought to be really outstanding science. But the big comment was, dystonia is not really an important disease, so let's not fund it. That was a big effect, a big impact. But the DMRF started lobbying NIH. That grant was resubmitted with almost no change other than pointing out how dystonia is important, except the DMRF lobbied to explain to the NIH how it was important, and it went from being rejected, or what was the 98th percentile, that's as bad as you can get, to being the 3rd percentile and was funded. And I know well about that grant because that was mine. So thank you, DMRF, for getting me going. Even though you didn't fund my grant, you made it possible. And the number of grants studying dystonia has continued to increase over the years. Now, let me go through some of the various kinds of research that have been developed over the years. And I'm going to put these in different categories, although they also overlap to a great degree. And I'm not going to do them necessarily in chronological order, but what I think makes more sense for understanding. The first most important thing that had to be figured out with dystonia is, what is it? What's the phenomenology? What does it look like? What is dystonia? What kinds of manifestations do people have that we call dystonia that before that wasn't clear at all? And I'll give some examples. Then I'm going to talk about some advances in genetics and what happened with that, and then how we understand what goes on within the brain and the pathophysiology. And then finally, I'll finish up with some treatment advances that have occurred over the year. And throughout, I'll explain how the DMRF has been absolutely critical. So let's talk about phenomenology, and I just can't help but to return to this fellow, David Marsden. So David Marsden and Stan Fahn were really the two major proponents for understanding dystonia early on. And it was described back in 1911, even before that. There are many different pictures of it, but there was a lot of disagreement about what would be constituted as dystonia. So much of the early work, when there were things like writer's cramp, for example, it wasn't clear that that was a dystonia, except David Marsden with Mike Sheehy then described that as a manifestation of dystonia because it looked like a part of what people with generalized dystonia would have. And so then there became this notion of focal dystonias and task-specific dystonias, and this developed over the years. And now if you really have good ears, you can hear the people cutting the lawn next door to me, and I'm sorry about that. So then there was a number of phenomenologies that needed to be sorted out about dystonia, and this was done by a number of people. And the first really big publication that put many of these things together was an Advances of Neurology volume that came out of that first international symposium. And this is when the DMRF was first put together. And that really started the ball rolling. And the kind of stuff that occurred in the phenomenology, and this is showing stuff from Stan Fahn's group where Susan Bressman was involved. And really what they did was they were looking at the people in their center. What kind of dystonia did they have? Sorry about that. What kind of dystonia did they have? Was it limited to just one part of the body we call a focal dystonia? Did it involve a couple of parts of the body related, or was it generalized? And what this is showing, what they published many years ago now, was the people that predominantly had generalized dystonia started at a younger age, whereas the people with focal dystonia, where it would start in a part of the body and not spread as much, and we'll talk about that spread in a bit coming up here, that tended to start at an older age. This was really a very fundamental observation that is proven over and over again. But this kind of classification of childhood onset versus adult onset led to a major advance in understanding the cause of dystonia. And that's what Xander Brakefield, working with Laurie Ozelius here, and with the phenomenology described carefully by Susan Bressman and her team with Stan Fahn, were able to then identify the first gene that caused dystonia. And this was that very well-known publication in 1997 that Laurie Ozelius, actually doing the genetic analysis, was able to do. And what they did was because of that observation about young onset, they focused on young onset, families that had more than one person affected, and they noticed that people with Ashkenazi Jewish background, those who came from the Eastern Europe, versus those non-Jewish, they had a higher chance of having a distinct genetic abnormality, that they were able to identify and do this kind of analysis because of these observations of being able to classify people childhood onset. That was much more likely to have this kind of genetic abnormality. And that abnormality first found was a GAG deletion, a specific deletion in the DNA on chromosome 9. This was a fundamental breakthrough. Now, that didn't affect most people with dystonia. That was really more for childhood onset dystonia, and people with adult onset dystonia were far less likely to have it, although some families where members would have this abnormality could have just a focal part, but other family members may have a more generalized type. And so this understanding of the phenomenology helped us to do the genetics kind of research that would help to select participants for these genetic studies that made them much more effective. Well, additional phenomenology has been worked on by the Dystonia Coalition. And the Dystonia Coalition, led by Buzz Jenna at Emory University, and he put this thing together. And I have to say, the reason he put this together is because Malin DeLonghair, who was the scientific director before I was, and was for many years, has been an incredible mentor and a pusher. He sat us down in an airport lobby or a hotel lobby and told Buzz and me that we had to apply for this big grant at the National Institutes of Health for to support rare disease research. And the only way this was going to happen is if we could work together with the DMRF to make this reasonable. And so Buzz put it together, put this application together, and Janet has done a major job with Jody and all the rest of the people at the DMRF, has really made this collaborative effort possible. And the reason I'm bringing this up is this has now led to a number of additional studies to help understand the phenomenology of dystonia. And the way it's done that, first, it had a major part of this study was doing a natural history. What happens to somebody when they have dystonia? Is it going to spread to different parts of their body, or does it just stay in one place? And the previous information that we had was always what we call retrospective studies, where there would be small groups at individual centers that would look at a small number of people and try to figure out what happened to them by looking backwards. Well, instead, you can get better data by looking forwards and then describe them. And so in this Dystonia Coalition, over the course of the last 10 years, we've been able to recruit over 3,200 people with dystonia from recruiting sites not only in US and Canada, but in Italy and Germany and England and Australia and New Zealand, really throughout the world, in Israel. So we have a number of recruiting sites around the world. And again, this is only possible because of the DMRF really managing a major part of the administration of this grant. And so by having the strength of looking at all these people, we can make a number of observations that we were not ever able to make in the past. For example, this is just one. This is now looking at people who had onset of dystonia in their neck, so-called cervical dystonia. And the question was, how often does that spread? And it turns out people that start with focal dystonia in their neck spread about over the course of 5 or 10 years. About 18% of them spread to other parts of the body, and these are the different parts of the body that it spread to. And this analysis of the data that came from the Dystonia Coalition was done by Scott Norris. So how does this relate to DMRF besides helping to recruit and keeping the Dystonia Coalition going? Well, Scott Norris was a young fellow just starting in our center and was trying to figure out what he was going to focus on. And the DMRF had a grant opportunity called the a Dystonia Clinical Research Award, or Dystonia Fellowship. And he applied for that and received it. And since that time, that totally turned him around to focus almost entirely on dystonia. And now he's really taking his career going forward. And I'm going to give you a little bit more data about what he's done that's been really very, very important. So training for the DMRF turns into not only clinical care, because he takes care of a lot of people with dystonia, but also helps promote research. So the Dystonia DMRF can support individual projects, which is great, but when you support an investigator, you get a career's worth of return on that investment. Another example of what's come out of the Dystonia Coalition is this study recently published by Brian Berman at the University of Colorado. And what he did is he's now looking at people with hand dystonia, laryngeal dystonia as it affects the voice, blepharospasm affecting the face, versus those that's shown here. And what we're seeing on this graph is the risk of spreading to other body parts after it starts. And so now this is a prospective study looking at the risk and seeing when dystonia starts in the face, it has a fairly high risk of spreading to other parts of the body. Whereas if it starts in the neck, just like I told you previously, relatively low risk, or if it starts in the hand, it's also much less likely, as is if it starts in the voice box. This is important information, and using this kind of information is absolutely critical for designing a study. If we wanted to give a drug or test a drug to see if it could slow the progression or spread of dystonia in an individual, the way we do such a study is obviously we have to have a drug that we think might work, but the way we do that study is we have to have an idea of what the risk of spread is, and that can tell us how many people we need to actually obtain to do the study and how long we need to do this study for. So these data that you're seeing on this slide make that kind of study possible. Without this data, you can't even test a new drug. If we have an idea of what something could totally stop dystonia, we couldn't test it until we had these kinds of data. And this is coming from the Dystonia Coalition. Other work from the coalition, and I'm going to talk more about other things too, don't worry. But the coalition is also here. Cindy Kamela from Rush University, just recently retired, but still involved with the coalition, asked the question, how can we better quantify the degree of severity of dystonia affecting the neck? And she developed, and actually there was already a fairly good rating scale called the Twisters, developed at the University of Toronto with Tony Lang and his group, but she included now a number of non-motor elements, things like psychiatric manifestations, depression, those other things that also affect quality of life, and developed that through the participants in the Dystonia Coalition, and then was able to validate it. Again, another key component before doing studies that can actually see if they can help or slow the progression of cervical dystonia. Another project that had been done was headed by Christy Ludlow, originally at NINDS, and then moved to James Madison University and just subsequently retired. Not that the coalition promotes retirement, by the way. And her focus was on laryngeal dystonia, or spasmodic dysphonia, as it's sometimes called, that affects the voice. And the idea behind this study initially was to develop metrics of the severity, again, so we could test different interventions to see how they would work. But along the way, we found out that the major experts in dystonia across the country didn't necessarily even agree on the diagnosis of different people. This was a real challenge. So we changed the direction of that research, and Christy led a major effort that used what we call a modified Delphi approach. In other words, got the experts together and then established revised criteria that now substantially enhances the ability to have agreement about what is this condition. Can we identify it? Can we agree that this person has it? That's a very important first step to go on to do additional studies. And that was a very major benefit from this research. Now, other kinds of, now I'm going to go away from the Dystonia Coalition and talk in large part. And this is what is going on in dystonia. Is it primarily just a motor problem with movement, or are there other manifestations? And the reason this is pertinent for a number of reasons, actually. So people with dystonia, which would have peculiar types of twisting postures, for many years was thought to be actually just a psychiatric disorder. It's, quote, all in your head. And people would be sent to psychiatrists, and psychiatrists really weren't very effective at treating this because it wasn't really that kind of a condition. And then there were studies in the 70s. In fact, one of the early studies by David Marsden's group with Michael Sheehy was looking at writer's cramp, and they very carefully analyzed these people and found, and this was a major breakthrough, they didn't really have other psychiatric manifestations. And then so for a while, the psychiatric components, or whether there's depression or anxiety, wasn't really addressed in people with dystonia. But then later, it became people focused more on those manifestations, recognizing that people with dystonia caused by DYT1, that genetic defect that I told you about earlier, can have depression and anxiety. It's not necessarily, it isn't causing their problem, but it can contribute to their angst and difficulty in dealing with the problem. And similarly, people with myoclonus dystonia, or these jerks that can occur in people that have dystonia, that is a separate condition caused by selective genetic defect now known, also may have psychiatric manifestations. And as I mentioned just recently, a few slides back, even in cervical dystonia, there may be excessive depression and anxiety that can occur in these people. And we've now found this in multiple forms of dystonia. And the reason this is important isn't that it causes the problem, but it can be an accompanying problem that we need to address. We cannot ignore it because it can cause people discomfort. And so recognizing the multiple manifestations that dystonia can affect people and families is really important to bring our best treatments for all components and how this affects people. And so psychiatric issues, no, yes. The answer is very well, maybe very important for selected individuals and not to be ignored. Now let's turn to the genetics. I mentioned the first gene that was identified with Lorio Zelius and Xander Brakefield's lab, identifying that because of the outstanding phenomenology work, or the classification of patients done by Susan Brespin with Stan Fahn and their group. And the tricky thing here was, even if people had the abnormal gene, only 30% of those on average would ever develop manifestations. So that's what made it very difficult. But subsequent additional genes have now been identified. This FAP1 can cause a childhood onset disease. It may have penetrance in the range of 60%, but the data for that is still a little bit fuzzy. It's not quite so solid, but the latest genetic abnormality that's very interesting is this KMT2B mutation, which now develops a childhood onset type of dystonia. And there's increasing data about this. And it's very important to understand what causes an individual's dystonia, because it also may have an impact on how they respond to treatment. And I'll talk about that a little bit more later, but just to jump ahead, this DYT1, now sometimes called TOR1A, same thing, and KMT2B respond well to deep brain stimulation. And so sometimes these kinds of component causes have an effect on what are the appropriate treatment strategies. Now, another form of dystonia that's genetically based are the Dopa responsive dystonias. And this is really probably the most important group to identify early on, because these people can respond to just a very low dose of Dopa, and that may make their dystonia just absolutely melt. And this particular condition is caused by a defect in two different genes. One is the gene that makes GTP cyclohydrolase, which is an enzyme in the body that's a cofactor for making tetrahydrobiopterin, which is a cofactor for this little guy, TH, which is tyrosine hydroxylase. And it turns out this enzyme is the key enzyme that takes tyrosine to L-Dopa, which gets converted to dopamine. And this is the rate-limiting enzyme. In other words, the choke point, if you will, for the brain to produce dopamine. And without this guy working well, there will not be enough dopamine. And that's why these people get dystonia, because they have a lack of dopamine. And that's why giving L-Dopa in a small amount can replace that missing dopamine, because this machinery converting Dopa to dopamine is totally effective. And so that will help respond. Now, they also much less commonly can have a defect in this enzyme or the gene for that enzyme directly. They can have lots of other problems. That's a more severe disorder. But this Dopa responsive dystonia is really an important one to exclude when people are found to have dystonia, because that's one that may melt very simply. Now, what else is the importance? What other important factors do we obtain, or is there value from identifying a genetic defect? So genetic defects are still very uncommon to identify overall in people with dystonia. They're more common in childhood onset, but the adult onset focal dystonia is relatively rare. But still, there's huge value for everybody. And let me explain why that is. It turns out that it may be that looking at the mechanisms or identifying the mechanisms in the brain for how a specific rare genetic abnormality causes dystonia, if that can be determined, and you can find it out for another genetic abnormality and a third genetic abnormality, and then look to see what might be in common across those abnormalities, now we're talking. Now we may find something that's important for everybody or most people, even if they don't have that genetic abnormality. And so identifying every new gene abnormality is critically important. And so what I want to point out here is that first one, that DYT1 or TOR1A, that gene makes or codes for a protein called Torsin A. And so there's been a huge effort in trying to figure out what Torsin A does in the brain and how it goes awry in people who have dystonia, or what that genetic does for that. And there's a number of people that have been supported by the DMRF that have made tremendous breakthroughs on understanding torsin in the brain, and this is critically important. And so Bill Dower and Phyllis Hansen, Rose Goodchild, and Antonio Pisani, which I just love to say because I like to say his name, have done some incredible work identifying the various kinds of activity that what Torsin A actually does in the brain, how it works at the nuclear envelope, in the nerve cells, what other molecules are important for the function of Torsin A, and even when it's in the striatum, a part of the brain that's critically important for dystonia, how is it working? How does it affect other, not just dopaminergic systems, but cholinergic systems, which Antonio Pisani has done just incredibly breakthrough work on. And all of these people have had funding and started with funding from the DMRF. And just to give you a sense of that, if Bill Dower thought of a way to absolutely cure DYT1 caused mutation of dystonia, and he wanted to write a grant to NIH to do a big study on that, he wouldn't have a chance at all unless he had preliminary data. And the only way to get preliminary data is to get some money to help collect that preliminary data. Then you can write a bigger grant. And that's the role that DMF has been just incredibly effective at doing. So when Bill Dower wanted to start to look at Torsin A, not just going for the cure, but to understand it, he was first able to get seed money from the DMRF, which is then turned into major funding from other organizations. And that's true for all of these investigators. So it's been incredibly important. Now, the other kinds of work, and Janet told you that I do some imaging research, so I have to have a little bias and tell you a little bit about imaging research and tell you what its role has been, but then other components of physiology as well, and abnormal function. This is going back to try to figure out where in the brain is there dysfunction that causes dystonia. That was a very early question. So now I'm hearkening back to the early 80s. And there were clues from people who have dystonia just on one side of the body. And the first clue of that was people could have, if they had just one side of the body, frequently it would come after they had a stroke when they had weakness, and then later develop dystonia. And it turned out a lot of those people would have a stroke in the brain, and this is a CT scan, and this is the normal ventricles in the brain, and this is showing, it's a very old CT scan, so the resolution's not very good, but this is showing a hole in the side of the body, or the side of the brain opposite the side of the body that had the dystonia. And this was a hole or a stroke that had occurred in the striatum, the caudate and the putamen over here. And so it was thought that the caudate and putamen would be related to dystonia. Now, there were abnormalities found in multiple other areas in the brain, but this was probably the most common. And then we saw a person many years ago who had an accident and had sudden onset of dystonia on one side of the body, and his CT and MRI scans were totally normal, but we did a PET scan on him, and this is a slice across the brain. This would be where the nose is, the back of the head, and the left and the right ear. And this is an image of blood flow in the brain. And what you can see is there's very high blood flow in the putamen contralateral to the side where he had his dystonia. And this is showing the oxygen extraction from the blood, and there's a big hole here. So this part of the brain is not working right. That's what it tells us. It says this is an area that's dysfunctional. So then you can go into it in greater degree. So it's just really trying to give us the relationship of what part of the brain is involved versus what part of the body is involved with dystonia. And we'll talk about that and more. Then in addition, what we found in others is that even in a brain image of blood flow in people with dystonia that had adult onset focal dystonia, for example, hand dystonia or dystonia in the face, blepharospasm, if we looked at their blood flow image just in a very simplified manner, they look normal. But if we did something to them, for example, if we activated them, so if we had them open and close a hand, we could look with PET to see where the blood flow changes. And if we did that, we could see there's differences between people with dystonia versus people who didn't have dystonia. But that was kind of not a very good study. And I can tell you that because I did that study. It wasn't very good. I didn't even publish it. And the reason it wasn't very good is because the people with hand dystonia, when they move their hand, they weren't moving it in the same way that people without dystonia had. So I didn't really know how to interpret this blood flow response. So then what we did, we said, okay, let's just put a vibrator on the hand. Let's vibrate the hand and look at how the brain responds to that vibration. And here what you're seeing is a slice through the brain. This is a higher slice. And this is the left side and the right side. And this is a blood flow response to vibration in the left hand. So you see this in the right part of the brain, the sensory motor cortex. And what happened in people with dystonia is that blood flow response was substantially reduced. And it was reduced in the hand that had dystonia. It was also reduced in the hand that didn't have dystonia on the other side of the brain. And it was true even in people who had dystonia of the face. Then if we touched the vibrator to their face, we saw they had reduced abnormal response to that. Furthermore, when we took a person who had Dopa responsive dystonia, remember that condition I talked about, if we put them in the scanner when they weren't taking their medicine, they had an abnormal response. And if we gave them their medicine, then the response normalized. What the heck is going on with that? So that led us to this kind of investigation. And here is what we call a coronal section, or top of the head, bottom of the head, left and right side of the brain, and making a section through the brain, looking at it en face, if you will. And this would be the caudate and putamen. That's the striatum. This is that part of the brain that has the dopamine in it. And that's the area that we saw abnormal blood flow and oxygen extraction in our people, and place where the strokes occurred in people. How does that relate to blood flow changes that were occurring up here? Well, one way it may relate is described here in this diagram. And what this diagram, this represents, this part is the caudate and putamen, this part of the brain. And this part of the brain looks like spaghetti here, right? So it has a lot of connections that go through various parts of the brain that connect all the way up to this part of the brain. So in other words, we have connections that go through here and go through deeper parts of the brain and come out to here. And the key is a lot of those connections are influenced by the effects of dopamine. And dopamine can have effects at what we call D1 type dopamine receptors or D2 type dopamine receptors. And these are places where the dopamine acts in the brain and then affects how these pathways through the brain work. And so the question was, are these dopamine receptors abnormal in people with dystonia? And so years ago, we looked at way using PET, where we could do a PET scan of a person. Here's again a cross-section of the head. The nose would be here, back of the head here. And we could see after we inject this drug called spiperone that goes to dopamine D2 type receptors, that we could see this is the caudate and putamen. This is the distribution in the brain in somebody without dystonia. And people with dystonia, son of a gun, had a reduction. It was about 28–30% reduction. And in fact, the abnormality of this tracer in the putamen, this part of the brain, depended upon what part of the body was affected. So if they had the hand, so this is a picture of the kind of a cartoon of the putamen, and it's organized like this, and the hand area of the putamen that represents hand function had the abnormality, whereas people who have it in the face had it in the face area. So the distribution of the abnormality reflected what part of the body was affected. And then Brian Berman, working with Christine Simonian, when they were both at NIH, and they went their different ways later, working in Mark Hallett's group, figured out that with PET, they could look at the dopamine release in people who had either hand dystonia, writer's cramp, or laryngeal dystonia. And the dopamine release, and that was done, how did they get dopamine to be released inside the striatum? They would have people with hand tap their fingers, and that would cause activation of these parts of the brain and cause dopamine release, which you could detect with a tracer in PET by looking at a reduction in one of the tracers called raclopride. So this is a way of doing that, and they found fabulous data that showed people with writer's cramp had an abnormality when they used their hand, and people with voice dystonia had an abnormality in dystonia and dopamine release only when they spoke. So it was specific to the type of dystonia and the type of movement. So it caused this kind of selective change in the brain. And this is really a seminal type of observation that they made. And there are two different papers, one looking at voice and the other looking at writer's cramp. So then we wanted to know, were the D1-like receptors abnormal? So I'm going to tell you about a paper we published. We didn't find any abnormality. We looked in the putamen as a whole and looked at it in people with hand and face dystonia, and we didn't find a thing. We were wrong, by the way, and I'm going to show you why we were wrong, because Christine Simonian did a better approach. And what she did later, she used the same radio tracer we used, but now instead of looking at the putamen as a whole, she clued on, we should have done this, but she did it right. She did it absolutely right. She said what part of the putamen might be abnormal. And she found there's a specific abnormality in a different part of the brain for people with hand dystonia and a different part of the brain for people with laryngeal dystonia. Really, exactly the kind of thing we thought before, but we didn't apply it to the D1. She was smart enough to do that and really made a very important observation. And I'm going to give you some additional data of why that's so important in a moment. So this is very key. And furthermore, people looking at mouse models of the dystonia, the DYT1 mouse, this is a mouse that has this particular abnormality in it, and looking at they found that the dopamine receptor second type, the D2 type receptors are actually abnormally low. So it fits with the imaging data. So now we're having you can go with a mouse and look at very selective mechanisms and identify that. And here they found this D2 abnormality in their mice with this abnormality. And here's the mouse that has this genetic defect. It has this low D2 receptor, which it matches exactly what we found before. And in fact, this kind of abnormality was found by David Eidelberg in people with DYT1 dystonia. We found it in people with adult onset focal dystonia that wasn't DYT1. Again, showing you there may be commonalities across different types of dystonia. And so John Mink looked at how does this actually produce dystonia? How do these kinds of abnormalities in the striatum, these dopaminergic abnormalities, cause dystonia? And so he put together a model. If this is the kind of the striatum, the caudate and putamen, and he looked upon it as the center part, this D1 mediated fibers actually are the central part, what we call the direct pathway through they're the pathway that's important for helping us to select an activity. So we use that pathway. If I want to pick up a pen and write it, that helps us to pick up the pen and write it. Whereas the pathway mediated by D2-like receptors helps to suppress the movements around that selected action. So when you pick up a pen, your arm doesn't go haywire. And the notion was that in dystonia, there may be too much action of selecting and not enough inhibition in the surround. And this is called focus selection and surround inhibition that John had thought and developed really based upon his animal work. And that was the abnormality we found. And Mark Hallett has been doing studies of surround inhibition in people with dystonia for a number of years as well. And so what he looked at, and he focused on the physiology actually in the cortex in the brain. And his notion was in the cortical areas of the brain where people would selectively tap their fingers, or if they're a pianist, have to play, they have to have individuated finger movements very carefully. So they have to select that finger and suppress the surrounding fingers from doing crazy things, that there's a mechanism in the cortex of the brain that does that surround inhibition. And what he found is people with focal hand dystonia have abnormalities in that surround inhibition. And furthermore, in this paper that they showed, that abnormality is most pronounced when doing very subtle movements of the hands. And that's the 10% of the maximum force that the hand can do. But when then comparing, this is the people with dystonia versus controls, there's a big difference. But when you have them do a firmer movement, there's actually less difference between the controls and dystonia. And that's typical of the people with dystonia that really have problems with the very subtle type movements. But dystonia is not just the striatum. There may be other areas and of the brain that are important. And so this was a study done with FDG, or a way of looking at glucose metabolism with PET. That's done by Hutchison and his group, and David Eidelberg has done this, and they find abnormalities in the cerebellum, and they focused on that. And so the cerebellum, and this was people that had dystonia in the face, and David Eidelberg found abnormal patterns in glucose metabolism and other forms of dystonia that also included cerebellum. So there was notions that cerebellum also could be affected. And then Ellen Hess and Buzz Jinnah at Emory had done a number of animal models suggesting that cerebellum could be involved, and there are other forms of dystonia that clearly had cerebellar abnormalities. So now, how do we deal with this? We have cerebellum being potentially involved. We have striatum potentially being involved. Well, there's very cool work from Peter Strick's laboratory that actually says those things are connected. And what they did is they injected tracers in monkeys into the part of the cerebellum, and then they would see where those tracers would go. It'd go from one neuron to the next to see what's connected. And they actually found connections directly between the cerebellum and parts of the basal ganglia. This is the subthalamic nucleus, and relating to the cortex. So here again, cerebellum back here, here's the striatum over here, and the subthalamic nucleus would be down in this area. So there are actually physical connections. But now the notion is, so you find abnormalities in different places. Is it really as simple as just this part of the brain is not right and that part of the brain is not right? Well, a more recent approach is, let's look upon it as potentially networks may not be working. And a lot of the work on networks has been done with this kind of approach. And let me just tell you what this approach is. And these people are very critical for this approach, but they have nothing to do with dystonia. So this is Mark Rakel, who really, with his graduate student, Mike Fox, first published this paper. And this was based upon some observations that a guy named Biswal made about MRI scanning. And it turns out with MRI, you can measure the blood oxygen level dependent signal in the brain. So what? And if you look at it and you have people just lie in a scanner. This signal, if you just look at one place in the brain, yellow, and you do nothing, and you just measure it 300 times, for example, over 5 or 10 minutes, this signal bounces all around the place. But if you take a part of the brain, like right here, and you ask the question, what other parts of the brain are doing when this signal is bouncing up and down? There are specific areas of the brain, sorry about that, specific areas of the brain that are in lock sync. And these areas that are going together are correlated. We call those resting state functional networks. And this is a major observation. And Mike Fox and Mark Rakel published a bunch of papers. And I just point out, gosh darn it, I just point out Avi Snyder because he's developed actually many of the methods. And this is done by lots of different people around the world doing this kind of research. And the reason this is particularly relevant about cerebellum and striatum is if we take this part of the brain, here's the caudate, the anterior part and the posterior part of the putamen, and we ask what parts of the brain are they in sync with, we find this is what happens in people that are just healthy controls. This part of the brain is related to a big part of the brainstem. This is now a side view of the brain. This is the front, this is the back, top and bottom. Here's the brainstem, back here's the cerebellum. So the cerebellum, it actually has a functional connection, not just a structural connection, but now also functional connectivity. And that's very important to understand. And then so a bunch of studies have been done now using these resting state networks. And so here I'm going to give you a little bit of caveat. So here there's a lot of studies, and this is one published, a couple published by Christine Simonian, describing major large-scale network changes throughout the brain in people with various kinds of dystonia. In fact, even specific types of laryngeal dystonia, whether it's breathy laryngeal dystonia or tight laryngeal dystonia, so-called abductor versus adductor, major changes and differences in writing cramp with large network differences. Then we recently did a paper, and it's just coming out, and again, here comes Scott Norris, working with an MD PhD student who, by the way, is now Dr. Amy Morris, and they found very small-scale network changes. And what they did, and so now with one hand I'm going to take and one hand I'm going to give, what they found is they used that part of the putamen that Christina Simonian had identified with her D1 abnormality on the PET scan and used that as a seed region. And that particular part of the brain now has abnormal connections in people with dystonia compared to healthy controls. It's absolutely selective and specific for what she saw. So what we're doing now is giving you functional relationships about different networks in the brain related to her observation. Interestingly enough, and this is where the take-its is, if we use very rigorous quality control on these kinds of studies, in other words, control for a little tiny bit of movement. When I say a tiny bit of movement, I'm talking about even 1 or 2 millimeters makes a huge difference. And if you take analysis and you look at people who move a lot versus eliminating the movement and dealing with it, you see with a little bit of movement not removed, you can get lots of statistically significant large connections that seem to be statistically significant, that when you do this kind of quality control, they actually go away. And so rigorous control is going to be very important for interpreting these resting state studies. Okay, quickly finish up here. Treatment, that's the most important part, right? So I already told you about Dopa. Responsive treatment really started with Toby Nygaard working with Stan Fahn, where he really described these people well, and David Marsden. And this is very seminal. Make sure we know that people with dystonia, if they have generalized or childhood on dystonia, any question, give them a trial of Dopa, and that's really critical. Then botulinum toxin has made a huge difference, and that started by this guy, Alan Scott, an ophthalmologist, who really started to do this because of kids with cross-eyed. He said, why don't, instead of cutting those eye muscles to get them balanced, why don't we give a little injection of this botulinum toxin to weaken that muscle and get them straight? And then Joe Jankovic went up there with Matty Lou Koster to try this in people with dystonia around their eyelids, blepharospasm. It was amazing. And then Mitch Bryn took off with it, and Joe Choi in Vancouver. And that's been just incredibly effective for a lot of people with dystonia, but not everybody, but it has a major role. And then deep brain stimulation really pushed originally with Malin DeLong and Anders Lozano and Phil Starr and Jerry Vitek, just a whole bunch of people. And Jill Ostrom working with Phil Starr has really pushed this forward. And we see its interaction with genetics, DYT1, the other genetic abnormalities may respond, and now this may also work in a whole host of different kinds of dystonia. And the targets that we may use, it can originally was put the stimulators in the globus pallidus, and now the subthalamic nucleus may be very good, and this is pushed by Phil Starr, and they show the pros and the cons. So this has been a major advance. So what's the DMRF doing? They have unique opportunities because they've promoted these pilot studies. They can target and get things going. It's just incredible. They've brought on new investigators, Phil Starr, Jerry Vitek. All these people got their start from DMRF funding or training. And the other thing they've done is they've pushed sharing data. Like they've helped the Dystonia Coalition, but the whole purpose of this is to share data. And that helps promote research, gets other people into the game, and also produces reproducibility. So the DMRF, you've done an incredible job, and they're continuing to move forward. Here's the new CEO of the DMRF, or the president, I should say, of the DRF. Janet is the executive director. And Jan, who we heard about, is their scientific director. Richard Lewis is head of the science committee. And we always have Malin DeLong as really a mentor, as Stan Fon, and we think about David Marsden over the years. I really want to thank the DMRF. I talked way too long, but I just couldn't resist.
This was great. Thank you so much. Do you have time for a few questions?
I'm here.
Great. So we had first of all, I was remiss in not letting everybody know at the start that this is being recorded. And so it will be available for everyone to watch, and for those who weren't able to join us tonight to view, at their leisure. So my apologies for that. We had a couple of questions about what is the relationship between Parkinson's disease and dystonia?
Okay, so much closer than we thought. And Denny Brown years ago used to call the flexed posturing of Parkinson's dystonic. And he was probably right. So the relationship is the following. They both involve, or may involve, the striatum. They both involve dopaminergic mechanisms. In some cases, there's a deficiency of dopamine, like in Dopa responsive dystonia. Some people with Parkinson's begin with dystonia in a foot, for example. That's a common way for Parkinson's to start. So if an adult begins with dystonia in a foot, that commonly can turn into Parkinson's disease down the road. It doesn't have to. Whereas a child, if they begin with dystonia in a foot, that's a common way for a child to begin with a generalized dystonia, and they never become Parkinsonian. So they have similar, they involve similar parts of the brain in different ways. Some of the manifestations overlap. So people with Parkinson's, when they're treated with too much dopamine or too much Dopa, they can develop dystonia. If they're not enough, they can develop dystonia. So there are a lot of relationships there, and a lot of overlaps.
Okay, great. Also, a couple of questions around family history with different forms of focal dystonias, and wanting to know whether or not there's any way to predict whether the next generation may develop any form of dystonia.
Sure. So let's start off with, first of all, with the one that's understood the best, and that's the TOR1A, or the DYT1 dystonia. So that is classically the childhood onset dystonia that goes on to form a generalized type of dystonia as the person gets older. However, in those families, some people may have generalized dystonia, and another family member with the same genetic defect may just have writer's cramp, hand dystonia. So there can be variability even with the same gene defect. Now that's that form of dystonia. There can be families, for example, with cervical dystonia that runs in the families. There are some forms of some genetic abnormalities that can cause that. Sometimes we haven't identified that genetic abnormality. If we can identify the genetic abnormality in a particular family, then we can do predictive testing, and we can talk about what the risk might be for subsequent generations. So for example, if there's DYT1 abnormality in the family, we can test somebody who doesn't have dystonia and say whether they're carrying that gene abnormality. Even if they don't have dystonia and they have the abnormality, they can still pass that gene along, because remember, they only have 30% penetrance, and so they may never show manifestations, but they can still pass that risk along. So we can do that kind of genetic counseling. And so to be able to counsel really requires knowing the gene abnormality, or being able to do what we call linkage analysis, which is not nearly as good as identifying the gene, the specific gene abnormality. And so these days we would do whole genome screening and try to identify that if possible.
So we have a couple questions on genetics, and one is that just with the rate of new gene discovery, how does that affect a parent's sort of approach to getting their child genetically tested if they have tested negative for the DYT1 gene thus far?
Yeah, so so the major advances right now are really incredibly fast, and my bias is the following. If we don't know the causative gene in your particular family, pretty soon, for even $1,000 or even much less, we're going to be able to do whole genome testing. We're going to be able to sequence all the genes for much less than we can do a panel of specific tests. And it's that kind of whole genome sequencing with careful analysis that may help us to identify genetic abnormalities in these families where there's more than one person affected. If it's just a single person that's affected, then it's going to be much more difficult to identify. So if there's more than one person, it's what we call a multiplex family, so at least two people affected, then we have a chance of being able to find them.
Okay. A couple questions about the relationship between essential tremor and dystonia. Are they different?
So our notions of what we call essential tremor is changing in the last few years. But let me first put it in this way. So with the Dystonia Coalition, for example, when we looked at people with neck dystonia, and there's a little noise in the background, let's see if I can get that a little quieter. So we found that people with neck dystonia, 60% of them had tremor of the neck area. About 20 to 30% also had tremor in the outstretched hands, where there was not dystonia apparent. And we would, in the past, call that essential tremor plus neck dystonia. But it's much more common in people with dystonia than in people without it. So now maybe the better terminology would be postural or action tremor with dystonia. How that's related, we still don't know, but that's where, now that we're getting that information, we can do that kind of a genetic analysis and see if there's in fact a relationship. The data on essential tremor, looking at where the problems are in the brain, typically most of the evidence is cerebellum or its pathways that connect it. How that relates to people with dystonia and people with dystonia with tremor, without tremor, remains to be determined. But this is a hot area of research right now. And in fact, even saying somebody with dystonia doesn't have tremor depends upon how carefully we look. So for example, Amy Morris, that MD PhD student who was looking at musicians' dystonia, so-called embouchure dystonia, people who have it in their lips and mouth area, and people who play the horn or the trumpet or the trombone, we would hear them play and they would have dystonia of their lips. But when doing careful and voice analysis, analysis of the sound, everybody had tremor. So it's, again, it depends on how carefully you look. So I think they are very closely related. Exactly how, we still don't know.
And could you comment on the status of research into magnetic, transmagnetic stimulation as a potential treatment for dystonia and ultrasound?
Okay, so there's a couple of different things there. So TMS, or transcranial magnetic stimulation, is a way of outside the scalp giving us magnetic stimulation, which can change some current flow in that part of the brain underlying it. And by doing that, one can alter the, presumably, the cortical inhibition, and help to, the idea is to transiently treat the dystonia. This is the kind of work that Robert Chen has been doing a lot of work on in Toronto. Mark Hallett's been interested in this at NIH and NINDS as part of NIH. And so a number of people, a whole bunch of different people in Italy are working on this, people in England have been working on this. Rothwell has been doing a lot of work, and they're just incredible work. So this has potential. One of the key things is how to select exactly which part of the brain really interacts with this whole notion of networks. And so trying to figure out which part of the brain, how to affect it. Is it just that outer part of the brain that we need to affect, or do we need to affect the network? And does this in fact relate to deep brain stimulation, which is much more invasive, where you put an electrode in the brain? Can we do it more easily by just putting this thing on the outside of the skull and affecting the same network that we do with the DBS? So there is potential here. And I think we need to learn more about the networks involved so we can do the kind of TMS with greater focus and greater understanding of the mechanisms that we're trying to alter. And so that's an approach that has, I think, a lot of promise.
Great. One last question. We have great questions, which we will utilize in future articles in the dialogue. So thank you, everyone, for your questions, but I want to be respectful of your time. What do we know about environmental factors that might trigger dystonia?
Oh, now you're making it hard on me.
Sorry.
So there are a number of different environmental factors associated with this. So one of the early ones was manganese toxicity. So acute manganese toxicity, people would get dystonia in their feet. They would get a little bit of Parkinsonism, and they would have a lot of dystonic type manifestations. We know people that received this neurotoxin MPTP that selectively destroys dopaminergic cells in the brain, which is a great model for Parkinson's, early on can develop dystonia right away. So that's another, and there's a lot of things that mimic that effect in the environment, like, well, some heavy metals may do that, but certain pesticides may do that. So there's an overlap here with the Parkinsonism and dystonia. So there are a number of different kinds of toxins that may cause dystonia or a transient dystonia on its way to leading to other manifestations. It's not usually an isolated dystonia, in other words, only dystonia. And that makes it a little bit more complicated to understand exactly what part of the brain dysfunction is leading to dystonia versus other clinical manifestations.
Great, thank you. I want to just give a shout out to everyone and your opportunity to participate in research through the Global Dystonia Registry, which you can find information about the registry on the DMRF website, to learn about clinical studies and trials when they're happening, very important. And also to think about, if you've not yet thought about it, becoming a brain donor. we sort of joke around the office, if your mother wanted you to go to Harvard, there's still time. You just do it many, many years from now when you no longer need your brain, but we need your brain. And we make it easy, and there's no cost to your family. And again, there's information on our website about that, and we're happy to talk with you about that. There's also a written report about the DMRF's research program and our accomplishments of the last 40 years that can be found on our website too. So I encourage you to check that out as well if you've not yet seen it. Dr. Perlmutter, this has been great. We're so grateful to you for the work that you do with the DMRF and your research and the work that you do with your patients. We're also grateful to all of our dystonia researchers and the dedication and commitment that they bring to their work, a number of whom joined us tonight. So a quick shout out to those, and many of them were featured in your presentation. So thank you to them for their work. We're grateful to our board of directors and all of our donors who make all of this happen. So thank you. And thank you again, Dr. Perlmutter, for this incredible program and for the work that you do. That's our program tonight, everyone. Thank you, everyone. Stay safe and be well. Good night.
Night.